Hello and welcome to the National Test and Discussion by Medico. I am Dr. Shashank Bell and I shall be discussing surgery questions over the course of 2 days. So let's begin. A 28-year-old female presenting with 36 weeks of gestation underwent a LACS for placenta accreta. During the procedure, there was profuse bleeding and she was transfused blood according to massive blood transfusion protocol. Which of the following is not seen after a massive blood transfusion? Now, before we move on to discussing this question, I want to point out something interesting, which is, right, so now this is a typical example of a question where you can ignore this. You can ignore this entire thing. Even if you read just the last line, that is, which of the following is not seen after a massive blood transfusion, I mean, that is enough for you to answer the question. So, whenever you see a question which is quite lengthy, what you can do is you can always read the last sentence. And supposing if you can answer the question based on that, there is no need to read whatever is given above that, right? Okay, so let us look at the complications of blood transfusion. The complication of blood transfusion can be grouped as that from a single transfusion and that from massive transfusion. So from a single transfusion are those complications which usually occur immediately, right? So those are incompatibility hemolytic transfusion reaction. This is due to ABO incompatibility. Febrile transfusion reactions, this is due to other antigens. Then you have allergic reactions, infections. So examples are bacterial infection, which is usually due to faulty storage. So blood is a good culture medium. So if not stored in the appropriate temperature, if there's some contaminant, some contamination in the field in the process of storing the blood, that can cause bacterial infection. Then you have hepatitis, HIV, malaria. Now air embolism, obviously, so as interns, all of you would have, whenever you're transfusing anything, you've been told to remove the air bubbles from the tubing, right? Supposing you do not do that, you can get air embolism. Thrombophlebitis. Now, air embolism and thrombophlebitis, you will notice, are not restricted to blood transfusion per se and can happen with any procedure where you're going to give an IV drug or fluid. Next is transfusion related acute lung injury, also known as TRALI. And this is, I'm sorry, this is usually from fresh frozen plasma transfusion, right? Now, what are the complications from massive transfusion? The complications from massive transfusion include coagulopathy, hypocalcemia, hypokalemia, hypothermia. So, these are all the hypo ones. Now, what you need to remember is potassium, you can get both hyper as well as hypo. So, as far as potassium is concerned, you have to remember both hyperkalemia as well as hypokalemia. Right now, patients who receive repeated transfusion. So, for example, if you have patients who are thalassemia, and these patients, they will require massive blood transfusions, right? I mean, they will require repeated blood transfusions. So, for these patients, they will also get a complication called iron overload, right? So, now one more question can be asked from this, and what is that question? So, they can also ask you, one moment. So, how much iron is present in 1 unit of RBC? So, each transfused unit of RBC, 1 unit RBC, it contains approximately 250 mg of elemental iron. So, moving ahead, what is the meaning of, so now that we've discussed the complications from massive blood transfusion, so obviously there's a question, what is the meaning of massive blood transfusion? Now, different textbooks give a lot of definitions, but what I've actually got from authentic sources are only two things. One is, if the patient receives more than the blood volume in 24 hours or more than 10 units of packed red blood cells in 24 hours. Now, these two mean the same thing, right? The normal blood volume is 5 to 6 liters and 1 unit PRBC, it contains 500 ml. So, 10 units will be 5000 ml, that is 5 liters. Okay, so moving ahead. Which of the following is true regarding hemorrhagic shock? So, just let us look at the types of shock before we look at the discussion of hemorrhagic shock per se. So, hemorrhagic shock can easily be, the classification of shock can easily be remembered by a mnemonic H code. I have been using this mnemonic myself since my UG days, where H stands for hemorrhagic or hypovolemic shock, C is cardiogenic, O is obstructive, D is distributive, and E is endocrine shock. So, all your other types of shock, that is anaphylactic shock, neurogenic shock, septic shock, those three types of shock come under distributive shock. So what are those three shocks? One is septic shock, anaphylactic shock, and neurogenic shock. Okay, so moving on to the question. Which of the following is true regarding hemorrhagic shock? So let us look at the options. Peripheral vasoconstriction. Now this is obviously false. Why is it false? So now, as an intern, whenever you've seen a trauma patient, you would have noticed that whenever the patient has shock, there are two things which you normally see. One you see is tachycardia. The other thing that you see is low BP, that is hypotension, right? So now why do you get this hypotension or low BP? That is because there is peripheral vasodilatation, right? Because there is peripheral vasodilatation, you're going to get hypotension. So peripheral vasoconstriction is wrong. Then anaerobic respiration produces carbon dioxide. Now all respiration produces carbon dioxide, but with anaerobic respiration what happens is it produces lactic acid, right? Now this lactic acid will eventually go on to form carbon dioxide, right? But the immediate product of anaerobic respiration is lactic acid. Okay, so let us keep this option as standby. Let us look at the other options. Now base deficit increases. Yes, this is true. Base deficit increases in all types of shock, irrespective of whether it is hypovolemic or hemorrhagic or cardiogenic or whatever it is. Irrespective of the type of shock, the base deficit increases in all types of shock. Next, renal perfusion is maintained till late stages. This is wrong. This is because even in the mid stages, the urine output starts to decrease. The urine output starts to decrease. So, the correct answer would be base deficit increases, right? Option 2, if you have to choose one option, you will obviously choose for base deficit increases because that is more correct than option 2. Okay, clinical features of shock. Now let us look at this very interesting table. Now shock, if you look at the grades of shock, it is, if you look at the blood volume lost, it is 0 to 15%, then 15 to 30%, 30 to 40%, and more than 40%. So this is grade 1, 2, 3, and 4. Right. Now easy to remember these percentages. Whoever has watched a lawn tennis game, a tennis match, so the scoring of a tennis match is the same as that of a grades of shock, right? Okay, so grade 1 is nothing but compensated shock. So what happens in grade 1? That is compensated shock, which is also called mild shock. So compensated shock means you are losing blood volume, but the blood volume that is lost is not enough to cause changes in your body. So that is, your body compensates for the loss of blood, right? So now supposing, say, many of us would have donated blood at some point in our life, right? So how much blood do they take maximum? They take a maximum of 500 ml. 500 ml is nothing but around 10% of your total blood volume. So that much amount of blood is not enough to cause any problematic changes in a healthy individual, right? That is why they screen for your health before you donate blood. So up to 15%, the human body can compensate for it. So what are the changes which do happen in compensated shock? So there is lactic acidosis, but it is very, very, very small. It is just 1 plus. The urine output here you see is normal, right? Conscious level, there is mild anxiety. So that is why, after you donate blood, usually they give the patient some fluid. So once they drink that amount of fluid, their anxiety goes away. The respiratory rate is increased slightly, pulse rate is increased slightly, but the blood pressure is normal. So this is why it is called compensated shock, because the urine output and the blood pressure are normal. Now what happens as you lose more blood? So uncompensated shock can be of moderate or it can be severe. Moderate is your grade 2 shock, that is 15 to 30%. Severe is 30 to 40% and more than 40%. So in moderate shock, the lactic acidosis, it increases, it is plus. The urine output is reduced. So notice that in severe shock, severe and uncompensated, the lactic acidosis is triple plus and the patient becomes anuric, right? So the patient is moving from a spectrum of normal urine to oliguria to anuria. right? So what I mean to say is this: renal perfusion is maintained till late stages. This is incorrect. So in late stages, the patient becomes anuric, right? So much before that, the patient becomes oliguric. Okay, so moving ahead. Conscious level, there is mild anxiety and compensated shock. In moderate, the patient becomes slightly drowsy, followed by he becomes comatose. Respiratory is increased in moderate, but it becomes labored. That is the patient's difficulty breathing in uncompensated shock. So why is there difficulty in breathing in severe shock? That is because, see, the blood contains red blood cells which will contain oxygen, right? So there is not enough oxygen in the blood. That is why the patient has labored respiration, and that is why the patient becomes comatose as well. So pulse rate is increased in all three, and hypotension happens. There is mild hypotension followed by severe hypotension. Okay, so now let us look at this very interesting and important table from Bailey and Love as to what happens in the different types of shock. So first let us look at these parameters. So first you have cardiac output. So now in hypovolemic shock, that is hemorrhagic shock, there is a less decrease in blood volume, so the cardiac output is decreased. In cardiogenic shock, what happens is the heart is not pumping adequately, so that is why the cardiac output is low. In obstructive shock, what happens is there is some obstruction which prevents venous return, that is the return of blood via the great veins, that is via the inferior vena cava and superior vena cava into the heart, right? So because less blood is returning to the heart, obviously the cardiac output will decrease. So in obstructive shock, the cardiac output will be low. Now what about distributive shock? So in distributive shock, what happens is there is vasodilatation, right? Along with vasodilatation, there might be peripheral shunting of blood. So blood starts to bypass the peripheral areas, and that is why more blood is returning to the heart, and that is why the cardiac output is going to be high. So what happens with systemic vascular is in the next parameter. So I told you that there is going to be so systemic vascularization, that is there is going to be constriction of blood vessels, right? So there is going to be hypovolemic. So in hypovolemic shock, it's going to be high. Cardiogenic shock also is going to be high. Obstructive shock it's going to be high. But in distributive shock, that is in the neurogenic, septic and anaphylactic shock, there is going to be peripheral vasodilatation, right? So since there is going to be peripheral vasodilatation, you are going to get a low systemic vascular resistance. Then coming to venous pressure. So venous pressure is going to again be low in hypovolemic shock and distributive shock. It's going to be high in cardiogenic shock and obstructive shock. So what is this venous pressure? So why is it high in cardiogenic shock? Now because there is some pathology in the heart. For example, there is a cardiac tamponade which is preventing the heart to pump blood adequately, right? So the pressure in the vein just before it, that is in the central venous pressure, it is going to be high. Same with obstructive shock as well. There is going to be a pathology which will prevent the blood from entering into the heart, right? That is why the venous pressure is going to be high in obstructive shock as well. Whereas in distributive shock, you have more of the blood in the peripheral, because of peripheral vasodilatation, there is going to be more blood in the peripheries, right? So the venous pressure is going to be low in distributive shock. Next, what is this mixed venous saturation? So what happens is, now, see, this is the heart. You have blood leaving the heart via arteries. Okay, blood is going to reach the tissues, and blood is going to return to the heart via veins. So let us say, now why is blood being delivered to the tissues? To deliver its nutrients. So let us say that in the heart, the blood starts from the heart with 100% oxygen. This is just to illustrate this example. These are not actual numbers. So when it comes to the tissues will extract some amount of oxygen. So maybe the oxygen will decrease. So maybe they extract 20% of the oxygen, right? So minus 20%. So by the time the blood reaches the heart, it is going to be 80%. This 80% is called your mixed venous saturation, right? So now what happens to mixed venous saturation? All the types of shock. So now the so what happens is, since there is a shock state, there is hypoperfusion. So the tissues are going to extract more oxygen from the blood, right? That is why the mixed venous, so here it was 20%, you're going to get 80%. Now, supposing the tissues were to start extracting more amount of oxygen, then what would happen? Then this would be less than 80%. So, it is low in hypovolemic, cardiogenic and obstructive shock. It is high only in distributive shock. Now, why is it high in distributive shock? So, in distributive shock, what happens is there might be some productions of toxins, that is endotoxins in septic shock, right? So, because that what happens is that these toxins, they cause shunting of blood from the, so you have arteries, capillaries and veins, right? So, what happens in distributive or endotoxic shock is there is shunting of blood directly from the arteries to the venules, from the arterioles to the venules. So, the capillaries, since it is bypassing the capillaries, the tissues are not able to extract the oxygen. That is why the mixed venous saturation is high in distributive shock. Now, base deficit will obviously be high in all. Instead of going, since the base deficit is high in all the types of shock, there is no point in going into the logic behind it. In the interest of time, you just remember that base deficit increases in all the types of shock. The other parameters, somewhere it increases, somewhere it is high, so you should know the logic. But base deficit, since it is high universally, there is no point in going into the logic. So let us look at distributive shock in some amount of detail. So distributive shock, it can be a variety of conditions which includes septic shock, anaphylaxis and spinal cord injury. Right. So, inadequate organ perfusion is accompanied by vascular dilatation with hypotension. Along with that, there is low systemic vascular resistance, inadequate afterload and a resulting abnormal high cardiac output. This is what we already discussed in the table. So, what happens in anaphylactic shock? So, in anaphylactic shock, the vasodilatation. So, what is very interesting over here is the vasodilatation. Right, because in all other types of shock, you're going to get vasoconstriction, but in anaphylactic shock, you're going to get vasodilatation. So, in distributive shock, you're going to get vasodilatation, and the reason for vasodilatation is different in anaphylactic, neurogenic, as well as septic shock. So, let us look at the reason behind vasodilatation. So, in anaphylaxis, it is because of histamine release, right? In spinal cord injury, that is in neurogenic shock, there is failure of sympathetic outflow, and in sepsis it is because of endotoxins. So, if you know this much, it is enough. One important thing which I want to emphasize rather is in endotoxic shock there is maldistribution of blood flow at a microvascular level. That is, there is shunting of blood. So, there is arteriovenous shunting which is responsible for all those other changes. So, now what is this endocrine shock? Now, endocrine shock, it may present as a combination of hypovolemic, cardiogenic or distributive shock. So, if you go back to the mnemonic of H code, right. So, this endocrine shock, it can be a combination of hypovolemic, cardiogenic and distributive, right. So, apart from O, it can be a combination of the other three. Now, remember in massive blood transfusion, I told you that the complication can be both hypo as well as hyperkalemia, right. Similarly, both hypo and hyperthyroidism can cause endocrine shock. The other causes are adrenal insufficiency. So, in hyperthyroidism, what happens is you might get cardiac arrhythmia. So, you will usually get something called a high output cardiac failure. Okay. Which of the following is seen in neurogenic shock? Now, in all types of shock, you are going to get tachycardia plus hypotension, right? But in neurogenic shock, you're going to get the opposite of this. You're going to get the reverse of this. So, you're going to get bradycardia plus hypertension, right. So, this ulta thing, this reversal thing is called Cushing's reflex. And the reason behind Cushing's reflex is because of cerebral autoregulation. So basically the brain is trying to preserve its blood supply till the later stages. That is why you get this Cushing's reflex, which is nothing but cerebral autoregulation, and you get this ulta thing of hypertension and bradycardia, right? So which is the correct option? Hypertension and bradycardia. So moving ahead, which of the following is not a criteria for systemic inflammatory response syndrome? So now let us look at a few terms and what those terms mean. An infection means there is an identifiable source of microbial insult, right? That means we know that there is a source in the body from where microbes are going to enter the body. So that is infection. SIRS or systemic inflammatory response syndrome, it shows two or more of the following. So this is a spectrum. First you get infection, then you get SIRS, right? So in SIRS, it shows two or more of the following. So what can be seen? So there are 4 parameters, 1, 2, 3, 4. Out of these 4, you're going to get at least 2. So what are those? One is the temperature is more than 38 degrees Celsius or 100.4 degree Fahrenheit, or the temperature can be less than 36 degrees Celsius, that is less than 96.8 degree Fahrenheit. That is the first parameter. Second is the heart rate is more, 90 beats or more. So notice that even though the definition of tachycardia, the normal heart rate is 60 to 100 heartbeats per minute, and more than 100 is called tachycardia. So this is why students get confused. But in SIRS, it will be more than 90 beats per minute. Respiratory rate is if it is 20 cycles or more per minute, or if the partial pressure of carbon dioxide, the PaCO2 is more than 32 millimeters mercury, or that the patient is on mechanical ventilation. So 3 things under respiratory rate. One is the rate of 20 cycles per minute or more. Then is PaCO2 with 32 millimeters mercury or more. Third is if the patient is on mechanical intubation. Fourth is if the WBCs are 12,000 or more or less than 4,000, or if there are more than 10% band forms, right? So in this spectrum, you first have infection, then you have SIRS. From SIRS, how does the patient proceed? So you can get sepsis. What is sepsis? Sepsis means it is plus of the previous two. So there is an identifiable source of infection along with SIRS. Severe sepsis means sepsis plus organ dysfunction. So what do you mean by organ dysfunction? Maybe there is acute kidney injury, right? That is organ dysfunction. Then you have MODS. MODS is multiple organ dysfunction syndrome, where 2 or more organ systems are in dysfunction. So maybe the liver enzymes start to get deranged along with the creatinine. Maybe the patient goes into a comatose state, right? So MODS is very important because the mortality of MODS is very, very, very high. Okay, then what is septic shock? So septic shock means there is sepsis or cardiovascular collapse, which requires vasopressor support. So you would have noticed during your internship that some patients in the ICU are usually kept on NORAD or on any other vasopressor, right? Okay, moving on. A patient was received in the casualty following RTA. His BP was 90/60 and his pulse rate was 120. The ER physician asked you to replace fluid loss in this patient. What is the maximum flow rate of fluid with the IV cannula given in the image? Now, again, this is another example of a question where there is no need for you to read all the bullshit sentences given above. If you just read the last line, what is the maximum flow rate of fluid with the IV cannula given in the image, you will get to know the answer. So this is another example where you can save time by just looking at the last sentence. So this is a green cannula. In green cannula, the flow rate is usually 80 to 90 ml per minute, which, so if we were to choose in one, we would choose 86 ml per minute. Now, unfortunately, this is the kind of question where it is a purely factual based question. There is no logic to it. So if you want to memorize, see, when I was preparing for my NEET PG, if there was some question which I knew I would definitely forget in the exam. So for example, I was not that good with numbers. So when I would get such a question, I would just leave it during my preparation. I would obviously know the answer for this. So green cannula is 86 ml per minute. It is 80 to 90 because there are repeats, but I would usually conveniently forget the others. And so supposing, say, if you try to spend, the reason I'm telling you this, if you try to spend too much time on a memory based question, right? So say 2 months, 3 months before an exam, you spend too much time making elaborate mnemonics, but on the eve of the exam, so usually students have this problem with anatomy, right? You spend a lot of time memorizing anatomy, but one day before the exam, you're not able to revise it. So then on the day of exam, if that question comes, you forget it. So what I would do was, such questions where I felt I would spend undue time while preparing, I would just leave that question. I would leave the topic around the question. That particular question you always have to remember. So green cannula is 80 to 90 ml per minute. Okay. So let us move ahead. Which of the following, before that, so for IV cannula, the unit of measurement of cannula is gauge, right? So what is the difference between this gauge? What is gauge and what is French? So French is used for Foley's catheter, right? And gauge is used for IV cannula. In French, what happens is, as the number increases, the diameter also increases. But in gauge, as the number increases, the diameter, that is the opening in the cannula, it decreases. So it becomes thinner and thinner and thinner. Okay, moving ahead. Which of the following statement is true regarding venous access? So let us look at the options. Phlebitis is the most common complication of peripheral venous access. This is true. This is true. So let us look at this option. So phlebitis, that means inflammation of a vein, is the most common complication associated with peripheral venous access. So to reduce the risk, what happens is, it is recommended to regularly rotate the site of venous access and monitor for any signs of irritation. So what does this mean? This means you would have noticed that in good centers, in good hospitals, whenever you have sincere nurses, right? So these sincere nurses, what they do is, whenever they put an IV cannula, they always write on the micropore or on the tape over there as to what date it was inserted, and they typically rotate it every 3 to 5 days. This is why what is the reason behind this? Because see, this is a portal of entry, right? Skin is the best dressing, but an IV line is a portal of entry into the blood vessels, right? So supposing there is any contamination in the IV cannula, because wherever there is an IV cannula wherever it is being inserted, you're going to have, it is going to disturb the virtuous triad over there, and you're going to have blood clots. That blood clot is a good nidus or a good culture medium for bacteria, right? Bacteria can, and since the patient is already in a hospital environment, there is a very high chance of the patient developing an infection. So it is recommended to rotate the site of IV access every 3 to 5 days, right? One more thing is, you would have noticed in goods, I mean, not exactly good, but in centers where they are using expensive equipments, so they might use a transparent dressing as well. So why do they use a transparent dressing instead of the Dynaplast which you usually use in government hospitals? This is because when you use a transparent film to cover it, that is to put it in place, and if there is any signs of irritation, like if there is any signs of inflammation, if there is any redness or swelling or something, you can actually see it. Okay, so what is the second option? If arteriovenous fistula is present in a limb, avoid venous access in the same limb. This is also true. Why is this true? So in arteriovenous fistula, what happens is, if you see, an AV fistula is created to provide a high flow access for dialysis, right? And if you use that same limb for venous access, it can compromise the fistula. So that is why, to avoid risk of injury to the fistula, you do not put IV line in the same limb. Third thing, in central line, vasopressor for septic shock is given to avoid limb ischemia. This is also true. So whenever you are going to give vasopressors, you will never give vasopressors via the peripheral line. Vasopressors are always given via central line. So what is the reason for that? See, vasopressors are medications given in cases of severe hypotension, such as in septic shock, to constrict blood vessels and improve blood pressure. Administering vasopressors through a central line is important because these medications can cause severe local tissue damage if they leak into the surrounding tissues. Now, in peripheral venous access, the vasopressors That is, if you give the vasopressor via the peripheral veins, it may increase the risk of limb ischemia by causing extreme vasoconstriction in smaller peripheral veins, right? So, because the peripheral veins are very small, there can be a higher risk of vasoconstriction. That is why central lines are a more reliable and a safer route for such medications. So, this option is also true. Next option, isotonic saline and heparin is flushed to retain patency. This is also true. So, what does this mean? So, you would have noticed during your internship that whenever you are going to give, so supposing say if you're using an IV cannula to give an antibiotic in the morning, now you're going to use the same IV line to give an antibiotic in the night, right? So, the in between these two doses of medicines or antibiotics, the IV line is not being used. So, naturally the blood will tend to clot over there, right? So, that is why whenever you inject a drug into the IV cannula after many hours, it is quite painful for the patient, right? So, what advice do sisters give you? They tell you to usually, or your seniors give you, they tell you to use a small bolus and you flush that. Right? So, when you flush that, the clot gets dislodged. So, in government hospitals, we usually use isotonic saline. I did my internship in a government hospital, and there we used to use isotonic saline. Now, but supposing if you go to private hospitals, so there instead of isotonic saline, they use Heplock. Heplock is the trade name, which is nothing but it contains heparin. Contains heparin in very small doses. So, when you give Heplock, when you give heparin, what happens is it dissolves the clot. So, it is less painful. So, isotonic saline is commonly used for this purpose. Heparin and anticoagulant may be added in some situations. So, particularly in central venous catheters or ports to prevent thrombus clot formation. So in the reason I mentioned the expensive hospitals earlier, so in posh hospitals, they will be giving Heplock even in the peripheral lines, right? But even in a government setup, in central venous access, it is always recommended to give heparin in central venous catheters. Alright. Now, but the problem with heparin is the use of heparin, it varies based on clinical guidelines and the type of catheter. So, not all lines require heparin flushes. Saline flushing is often adequate, especially for peripheral IVs. So, this much information, if you know it, is enough. Now, I have added a bit more on the use of heparin. This is because since this question was asked, I have a strong feeling that if they want to ask around this topic, they might include questions on this. So, what is use of these heparin? So, heparin flushes are typically used where blood flow is slower and there is a higher risk of clotting compared to peripheral IV lines. So, now if you look at central venous catheters, that is if you look at the central line, right? So, now what are the types of central lines? You might have a PICC line, that is a peripherally inserted central catheter. You might have a tunneled CVC, that is a tunnel central line, which is, for example, you might have a Hickman catheter or a Groshong catheter, and you might have a non-tunneled CVC. So, Hickman lines are usually used, PICC lines, Hickman lines are usually used to deliver chemotherapy. So, in these central venous catheters, you have to use heparin. Now, why do you use heparin? One, like we discussed already, the blood flow is slower in CVCs, right? And since the catheter is going to be in place for long periods, so supposing say the patient has to be delivered chemotherapy via PICC line or via Hickman line. See, this PICC line and Hickman line are going to be inserted by surgeons. So, they'll obviously charge a lot of money, right? And if a surgeon is inserting a line in the OT, you obviously cannot remove the line immediately. So, it will be in place for a couple of months. So, that is why you will use heparin. Okay. Now, one exception of this is in the Groshong catheter. The advantage of the Groshong catheter is it has a valve. They have a valve, right? And this valve, it will reduce the risk of clotting. So, in Groshong catheter, you may not need heparin flushing. But for purpose of your NEET-PG, you need to remember that in all central lines, there is a high chance of using heparin. So, what are implanted ports? So, implanted ports are usually, in some centers, supposing if you were posted, like where I did my SR-ship in Kolkata, there we had an oncology unit, and interns are often posted in the oncology unit as well. So then they would many interns would come back and ask that they are sending the patient for a chemo port incision. What is this chemo port? So a chemo port is nothing but a medical. So supposing say it is most commonly given for CA breast. So these patients, whenever they would have CA breast, whenever they would need chemotherapy, many of them would be sent for a chemo port. So what is chemo port is? So they would come back and the port would be inserted directly above the tumor, that is under the skin. It was a subcutaneous port. Right. Now, why is this chemo port being inserted? Because see, when you in these onco patients, since they're coming to the hospital so frequently and so regularly, what happens is you you might have noticed during your internship. So whenever there's a patient, supposing if you've already used a vein for an IV line, it becomes difficult to use the same IV line after, in a very short interval. So the advantage of a chemo port is you can then give chemotherapy via the port itself. So an implanted port, an example is a chemo port. So implanted ports also, they have a higher risk of clotting due to low blood flow. That is why you would recommend to give the patient a heparin flush. Then you have hemodialysis catheters. Hemodialysis catheters, so for now dialysis, you require high flow, right? That is why you create an AV fistula. So these large lumens, they allow for rapid blood flow. But the problem is, since you're not going to use the hemodialysis on a daily basis, in between sessions of dialysis, it can clot. So to prevent clot formation between dialysis sessions, you will use heparin flush. Then in arterial line, in an A line, you will use heparin. No need to look at the logic. You just remember that heparin is often used in low concentrations. So peripheral IV lines, such as those used for short-term IV access, do not require heparin flushes. So in these lines, normal saline flush is enough. So peripheral lines are replaced every I told you 3 to 5 earlier. So every 3 to 4 days, it is changed. This is what the book says. But there is an exception. So for children and for neonates, you can keep it in place until it is no longer needed. But so you can keep it longer. But there is a caveat to that as well. That is, there should be no sign of infection. If there is a sign of infection, you will immediately remove the cannula. Okay, so let us discuss a bit more about central venous catheters. So, do you need to replace a CVC, a central line regularly? No, there is no need to replace or to exchange a CV line so frequently, as long as it is functional and it is not causing any complications. So, how long can you use a CV, a central line? You can use it for weeks to months. Okay. This is what I was talking to you about. This is the transparent dressing, right? So these transparent dressings, they are changed every 5 to 7 days, while the gauze dressings are changed every 2 days, unless they become soiled. Okay, so another topic which is a favorite among examiners is the color coding. So now when I was an intern, one of my senior PGs, they taught me a mnemonic for this, to remember this, and I remember it till date. So it is, oh God, why God, it is, oh God, why God, pink bra, yellow panties. So this is what mnemonic was taught to me by my seniors. So you have O is orange, this is 14, then you have 2 G's. So one G is gray, one is green. So how do you remember which comes first? You can use it as alphabetical order. So you spell gray as your gray anatomy, right? Don't spell it as how you spell it in English. So like your Gray's anatomy is GRAY, then you have white, then you have green. This is pink, B is for blue and yellow, and this P is for purple. Now supposing if you are confused as to whether which P comes first, whether it is pink or purple, again it is alphabetical order. PI is before PU. Same with G. it is alphabetical order. So the size of this is orange is 14, gray is 16, white is 17, green is 18, 20, 22, 24, 26. This is the best way of remembering the IV line. Here they've mentioned violet, but it is actually purple. Okay. So what color do you prefer in surgical wards? What color do you prefer in medical wards? So in medicine, when you're going to give the patient IV fluids, you would usually put a pink cannula in your medicine wards. Now, supposing if a patient comes to casualty, say with bowel obstruction or trauma, and you require to give more fluids. So in these patients, you will always use at least green. So you will use green or thicker, that is more fluids. You want to give more fluids because these patients might go into shock. Now, suppose if you go to the pediatric wards, there you will use the color B. B for blue, B for bacha. So B for blue, B for bacha is for in the pediatric wards. Okay. So I mean, many times as an SR, as a PJ, I've seen that many interns, when they were not able to put the pink IV line in adults, they would put the blue line. So see, the IV lines are being put to give fluids, right? And why is there color coding? Because the diameter, that is the internal diameter of the cannula, which is allowing for the fluid to flow, is different, right? That is why you have many color coding. So some situations we require fluids to begin at a very rapid rate, some at a very slower rate. So in adults, there is no point in putting a blue cannula, because that will not be enough to meet the fluid requirements of the adult. So let us look at some more questions which are asked from this gauge size. So supposing if you want to do an FNAC, then what gauge needle will you use? You will usually use a 23 gauge needle. So for convenience, it is grouped as 22 to 24 G. Whenever I have done an FNAC, I have always used a 23 gauge needle. So whenever they give spinal anesthesia, the needle is called a Tuohy needle, Tuohy. And this Tuohy needle, it has a diameter of 27 gauge. So supposing you want to do a co-needle biopsy, for example, if you want to do a true cut biopsy, the gauge size is 14 to 18 G. Now, many patients, so they have to take, many patients who are diabetic, they have to take insulin at home. So my father also takes Mixtard twice a day. So, and he usually has to administer it himself. Now, if you are administering insulin twice a day by your own, it has to be very, very, very less painful, right? So how do you make it less painful? By decreasing the size even further. So it is 31 to 32 G. And you know, companies advertise it by saying that it is just like a mosquito bite. Okay. So moving ahead, feeding is done through the given method, which is the following is not a complication. So now this is the method of feeding. This is a central line. So if there is a central line, obviously you're going to give that means the patient is receiving total parenteral nutrition. So which of the following is not a complication? Let us look at the options. So aspiration, pneumothorax, refeeding syndrome, and osteoporosis. These are the options, right? Now, when does aspiration happen? When you are swallowing something and it accidentally enters into the lungs. So obviously aspiration cannot happen via central line. So this is the answer. So pneumothorax can happen because of, so whenever you're inserting the IV line, it might puncture the pleura, might cause pneumothorax. Osteoporosis because of metabolic complications, refeeding syndrome also because of metabolic complications. So these all can happen. Aspiration won't happen. This is a common sense question basically. So, okay, one more thing is if you're given this kind of image in the exam, where you know there's something going into a neck vein, and you can see these two things coming out, 1, 2, 3. So you can see the various tubes coming out, and you can see it over here, 1, 2, 3. So this is usually this is a central line. Okay. So this is also a central line. So here see over here, it is the internal jugular vein which is being accessed. So the central line is going to go via the internal jugular vein into the superior vena cava, into the atrium of the heart. But here you can see the vein coming from below, right? I mean the line coming from below. So here they are using a subclavian vein. Let us look at TPN in a slight more detail. So what are the indications of TPN? So patients who are unable to meet the nutritional requirements via absorption of nutrients from the intestine, for example, short bowel syndrome or a enterocutaneous fistula. Then as a temporary measure, till the patient is able to start feeding themselves adequately. So for example, while the patient is waiting for an NJ tube, an NJ tube is also called a Frecker tube. Right, so this what you insert in what is a nasogastric tube, that is a Ryle's tube that you can insert on your own, but a nasojejunal tube requires an endoscopic assistance. So while the patient is waiting for the nasojejunal tube to be inserted, you will have to give TPN. Then malnutrition, sepsis, and any injury. Okay, so now let us look at the energy content of TPN. So usually it is in the ratio of 150 to 250 kilocalories per gram of protein nitrogen. Then 30 to 50% of this energy is going to come from fat. So why is this? Because this will ensure that so if you're going to get maximum energy from fat, that means the proteins or amino acids you're going to be giving are going to be used for tissue maintenance. So how do you give TPN? So it is usually administered via a central line, and that is into the superior vena cava or right atrium, or using a PICC line. What is a PICC line? PICC line is a peripherally inserted central catheter. So in a PICC line, you're going to go via your cubital veins and you're going to enter into the right atrium. Whereas in a central line in the neck, you're going to go directly via the internal jugular vein. So PICC lines are most commonly inserted through basilic veins. So basilic vein is the most common vein. Others are cephalic, brachial, median cubital vein. Central lines are usually inserted through the external jugular vein or the subclavian vein. Now this, how do you know that the line is in the correct place? It is considered to be in the correct place if the tip of the central line is in the inferior third of SVC. This is important. If it is in the inferior third of SVC or at the atriocaval junction. Now, if you give TPN via central vein, what is the advantage? Because if you're giving it via a peripheral vein, there's a higher chance of getting thrombophlebitis. Okay. So peripheral venous system are used rarely to give TPN. However, the newer formulations which are entering the market, they can be given safely via the peripheral lines. But peripheral venous systems is still used rarely. This is because TPN has a high osmolarity, right? And there is a higher chance of thrombophlebitis. So you can still give peripheral venous system, that is the newer formulations, to give TPN. So when do you give that? So supposing if you're asked a question and the question is something, the patient requires TPN for 18 days. So will you use a peripheral line or will you use a central line? Now the key in that is 18 days. If it is less than 14 days, you will use a peripheral line. If it is more than 14 days, then you will use a central line. So here in this X-ray, you can see that, this is the Ryle's tube. You can see those lead shots in the Ryle's tube. You can see this outline, right? So this is the Ryle's tube. Now you can see one more. Let me erase this first. So you can see one more tube which is coming like this, and it is going. So here, this tube is going further below, right? This is a nasojejunal tube or a Frecker tube. Okay. Now, see, what is this? This is nothing but a plate and screw. So this patient has probably had a fracture. Okay. So here you can see that, you can see this line coming, right? This is a PICC line. This is also a PICC line. See, this is the PICC line. Okay, so moving ahead. So what are the complications of parenteral feeding? So while inserting, you might get pneumothorax, you might misplace the line, you might get line complications such as sepsis or thrombosis, metabolic complications such as electrolyte disorders including refeeding syndrome, blood sugar derangement, liver dysfunction, metabolic bone disease, vitamin deficiencies. So these are basically common sense. There's no need to break it and remembering it. But let us look at refeeding syndrome in slight more detail. So what is this refeeding syndrome? So refeeding syndrome, as the name suggests, so when a patient has been starving for a long duration and suddenly you you restart feeds, those patients can get refeeding syndrome. So what happens is, so first thing is, it is happening after prolonged periods of starvation. So it is prolonged periods of starvation. Now what happens is, whenever you initiate nutritional support, that initiation of nutritional support, it can be either via a enteral route, that is via, you might ask the patient to eat, or via NGT, or via nasovaginal tube, or via TPN. So patients will have a dramatic shift of fluids and electrolytes, and that can cause this refeeding syndrome. So dramatic shifts of fluids and electrolytes which occurs early, and in late cases you might get hypoglycemic episodes. Now, suppose if you are given a clinical scenario and you have to identify whether it is refeeding syndrome or not. For NEAT PG, for your level, you will get one term which is the hallmark, that is, you will get hypophosphatemia. So whenever a clinical scenario is given and they mention that there is hypophosphatemia, it means the patient has got refeeding syndrome. So now, why is this dangerous? Because this hypophosphatemia, it can cause cardiac arrhythmias, it can cause myocardial infarctions, it can cause even cardiac arrest. That is why it is a dreaded complication. So now, how do you prevent this refeeding syndrome from happening? So before you want to restart feeds, you have to correct the electrolyte and the fluid balance, right? Now, supposing you've corrected the electrolyte imbalance, but you are still anticipating that refeeding syndrome might occur in this patient. So how do you prevent it? So you will have to use high doses of vitamin B, right? And you have to give daily vitamin supplementation. That is one thing. Second thing is, the feeding should be commenced at a slow rate, right? So you start giving the patient 10 kilocalories per kg per day. So in a malnourished patient of say 40 kgs, right? Maybe the patient has had CS stomach, the patient has lost weight, the patient has asthenia and anorexia. The patient's weight is now 40 kg. So in this patient, you will start feeding by 400 kilocalories totally, because it is 10 kilocalories per kg per day, and you gradually increase it over 4 to 7 days. Okay. Moving on to the chapter of wound healing. If open cardiac massage were to be performed on a patient, what category would it come under? So, there are 4 categories of wounds. One is clean contaminated, one is contaminated, one is dirty. This is a very important topic. Questions are very frequently asked from this. So what do you mean by clean wound? So a clean wound is a wound in which the tubes in the body are not opened. For example, respiratory, alimentary, that is the GIT, genital, or uninfected urinary tracts are not entered. So whenever these tubes in the body are not entered, then it is called a clean wound. For example, if you're going to do a hernia surgery, when you do a hernia surgery, or let us example, for you're doing a lipoma surgery. So here you are not going to be entering into any of these tracts, right? So that is why it is going to be a clean wound. Now, what is a clean contaminated wound? So for example, if you do a GJ, if you're going to do a gastrojejunostomy, right? So here you have to make an opening in the bowel, but you know that this patient, I'm going to open the stomach, I'm going to open the bowel. So you take precautions from beforehand to prevent leak. You might prepare the bowel in a case of colorectal surgery, or you're putting gauze pieces or mops to ensure that there is no soilage or contamination of the area. You might have a suction tube ready. So whenever there is a controlled condition, this is the key word. Whenever you are entering into these tracts under controlled conditions, it is called a clean contaminated wound. Now, what is a contaminated wound? So a contaminated wound, so for example, where you're not anticipating an injury, so the injury happens accidentally, right? Or so in that case, since you've not prepared the bowel, you've not prepared the bowel, that you might cause contamination. That is one thing. Second thing is, supposing the patient is coming with an accident, and it is a fresh accident. That means the patient has had an injury, and within a few hours, he's going to come to the hospital, right? So there is not enough time for the contamination to happen. So an open fresh accidental wound is called a contaminated wound. And here there is also one more category in this, is operation in which there is a major break in sterile technique, right? That means if there is gross spillage from the GIT, right, then that becomes a contaminated wound. Another interesting example of this is a open cardiac massage. See, if they ask you questions from spillage from the GIT, you will obviously know what the answer is, right? But open cardiac massage is something where you would not, you would have to think as to what is happening. So, for an open cardiac massage, it is a contaminated wound. Okay, then what is a dirty wound? So, a dirty wound is an old wound, or supposing say the patient has had gangrene. So, there is devitalized tissue for quite some time, and that is a focus for infection, right? Or maybe the patient has come with a duodenal perforation with a 2-day or a 3-day history. That is a dirty wound because there is gross contamination, right? Okay. So, let us move ahead. So, in the last couple of years, they're very fond of giving you an image and asking you to identify what instrument it is. So, let us look at a few images. So, this is a PEG tube. This is a PEG. What is this PEG? It stands for percutaneous endoscopic gastrostomy. So, percutaneous endoscopy, that means you're going to insert the tube with the help of an endoscopy. So, an endoscope is inserted. As the endoscope is inserted into the stomach, you can see where the light is, right? And depending on that, you're going to puncture the stomach immediately above that and place this hub. You're going to place this. So, whenever you see this, right, you know that it is a PEG tube. So, PEG is one of the options in this. Is a PEG tube. So, see, whenever, so you are given this complicated kind of thing, you don't know what it is. So, whenever you see this hub, right, whenever you see this kind of thing, you know it is a PEG kit. Okay, see here also you're going to see this is a PEG tube. So, this hub is actually okay. So, now let us look at the what this PEG tube is. So, this is the stomach. This is the stomach wall. This is the catheter which is coming in, right? You need to keep it in place via two things. So, those hubs which I was talking to you about, these are nothing but one is the internal bumper, which is keeping it placed from the stomach. One is the external bumper. Okay. So, this image you're going to see it is entering. This is the umbilicus, right? This is the umbilicus, and there is a tube which is entering into the epigastric region. So, what is there? What is there in the epigastric region? You have the stomach. So, this is a PEG tube. So, a central line, like I told you, central line is you're going to get it. So, here you're going to get 3 tubes, right? 1, 2, 3, and usually it is entering into. It is usually in the neck, basically, or it might be in the subclavian vein that is below the clavicle. So, that is an example of that is how you identify a central line. Also, whenever supposing say you're given a zoomed up image of this, okay. So, see, a central line is going to be kept for many months. So, you have to suture it in place. So, this is the wing of the central line. You can see these 2 holes over here. So, via these 2 holes, it is used to anchor it in place. Okay, so let us look at a chest tube or an ICD. How do you identify a chest tube or an ICD? So, you will get this tube. You're going to get obviously one opening in the at the tip of it, and you're going to get a lot of eyes over here. These eyes, right? So, this is how you identify a chest tube. Nasogastric tube or a rise tube, all of you can identify it. There are various color codings, and see this green thing over. This is it contains lead shots, which makes it radio opaque. Also, you can see this one green line, right? That is also radio opaque. So, in the earlier image where I was discussing what lines can be seen in the X-ray, I showed you this rise. I showed you one line, right? And that is the marking of the rise tube. Okay, so we'll take a small break over here, and after the break we shall continue.